I know, some and a bunch of new faces. Welcome. We have lots of time for questions. So any questions you have, just let us know. My name is Elizabeth Schoenfeld. I'm the Vice Chair of Research here at Baystate. And if you want to talk about research, we can talk about that too, either at the end or later. But this section is on social emergency medicine, which, as most of you guys probably know, is sort of a new term for a concept that's not new, but is sort of having a new term brings the field together and gets people on the same page. So the term social emergency medicine, I actually was like, do we have an official definition of it? We actually don't really have an official definition of it. Social emergency medicine, you guys all know that the emergency room is sort of the safety net of the US health system. And as the safety net, we see the social determinants of health in a way that other people don't necessarily see them. And we all recognize that there's this biological framework for how disease happens, and then there's this ecological framework, which is that what happens in our health and our health outcome is probably shaped more by the social factors around us than it is shaped by the biological factors. And the more we recognize that, the better we're actually going to do at affecting population health. So social emergency medicine is that intersection of those social determinants that affect health and our care in the emergency department. And I think more and more we recognize that the emergency room is actually a great place to start to address some of the issues where society is maybe failing a little bit. And our patients are really being hurt by some of these social factors that we see in the emergency room. Social emergency medicine both looks at this from a research standpoint, but also from an advocacy standpoint and an education standpoint. And we sort of recognize that this is not an individual physician's job to fix these things. This is a societal problem, but we all need to be there and be educated and show up to be able to improve the health of our populations. And that individual emergency departments themselves are sort of windows into their community. So how any emergency department is doing is how that community is doing, and how that community is doing is going to be reflective in the care that the emergency room is giving. And I think I'll give you a little quick background on Baystate. Baystate is the biggest hospital in Western Mass. We're actually a pretty big hospital system. There's 5 hospitals, but our individual hospital where the training programs are located is called Baystate Medical Center, and it's in Springfield. It's about a 750, 800 bed hospital. It's an academic teaching hospital, has multiple residencies. I won't get into all the details. It's a level 1 trauma center. In terms of patients, I think we see about 115,000 patients a year, which makes us one of the busiest hospitals in the country. Our acuity level puts us at one of the busiest hospitals in the country as well. The population of Springfield is, it's not a huge city, it counts as a small city, but it's a diverse and interesting population with a lot of immigrant groups and a couple of different refugee groups as well, but set in a sort of more rural surrounding area. So we actually see a little bit of the rural medicine issues that you see in other places and critical access hospitals as well. So we got a lot of interesting things going on. From a social emergency medicine standpoint, I'm one of the co-chairs of next spring's consensus conference. If any of you guys have been involved in Society for Academic Emergency Medicine yet, there's ACEP and there's SAM, and they work together. And ACEP is sort of the biggest umbrella and really includes anyone practicing emergency medicine, and SAM is a little bit more academic, so the people who are doing research and are working at training programs and that sort of thing. So SAM every year has a consensus conference, which is basically a conference on a topic that we decide upon, and it's different things each year. And this year, out of just complete coincidence, this past year it was telemedicine and the future of telemedicine and research on telemedicine, which made sense. And was completely accidental because it's decided 2 years ahead of time. But this coming consensus conference this next spring will be on social emergency medicine, both research and education and that sort of thing. And if you're interested in being involved, I can put the link to the volunteer form for getting involved in that. There is definitely places for med students and residents. And I am one of the co-chairs of that, along with Maggie Samuels-Callow, who is at MGH, and Michelle Lynn, who is at Mount Sinai. In Mount Sinai in New York and MGH in Boston. So I am going to introduce, well, actually, I'm going to let them introduce themselves, but I'm going to call out our other Baystate people who are here, and so they can tell you about themselves. Dr. Albert, do you want to start?
Sure, I'll start. So I came here to do my admin fellowship, and I finished about a year ago. I stayed on as faculty. So right now, I'm doing some things, focusing more with documentation, coding, and billing. The other thing I'm also working on is myself and Dr. Biaroel are starting a health equity fellowship. So we may not necessarily have applicants this year, but we're definitely recruiting heavily for 2021. And our hope is that we'll be able to, attract people who are interested in health equity issues and interested in doing research or doing community engagement projects. And so I'll kind of stop from there, and then we'll answer any questions you have during the Q&A.
Dr. Soares, would you like to go next?
Sure. Hi, everybody. My name's Bill. I've been at Baystate now for 7 years. I am a fellow researcher with Elizabeth. So about 75% of my time is research, and my research involves substance use disorders. So I heavily go back and forth between concepts of social emergency medicine and what we've done. So I'm also, although I've been doing it for a while, the newly minted director of harm reduction services. So a lot of what we do not only is working to implement treatment, things like Suboxone for patients who present with substance use disorder and opioid use disorder, but also to try to expand and actually give teachings and resources for actual harm reduction. So I think we're still one of the only places that does harm reduction kits and take-home Narcan, and we've been working on that through our 5-hospital system. Otherwise, being involved kind of in and with this population has also led to different outlets. So along with Vanna and a few others, especially as COVID hit, we worked together to organize resources for our homeless and at risk of being homeless populations, including our shelter populations, where we work to devise protocols with the city of Springfield and other hospitals to basically manage quarantine tents for our homeless populations. And so a lot from that aspect and other things, I have a lot of connections and work very closely with some of the organizations that are caring for our homeless populations even still. So, I think overall, Baystate Medical Center in general, there are the social determinants of health and the differences in socioeconomic status are really huge, and there are a lot of opportunities. I also think there are a lot of opportunities to kind of teach people that, addressing these things as an emergency physician actually matters and can save a life. Probably you're going to save more lives if you address these things than for every person that you lice their PE or, get ROSC or things like that. So we're really trying to instill that you need to know how to do that. That's definitely an important part of residency and being an emergency physician. But there are a lot of other things that you can address in the emergency department that really could impact and even save people's lives. So that's me.
All right, Dr. Biaroel. I'm like, shoot, I have to say Nadia's last name.
Hi, my name is Nadia Biaroel. I am an attending at Baystate. I actually did my residency at Baystate and completed it 2 years ago, and completed an ultrasound and research fellowship. And then this year, Van and I, are, like she had mentioned, are creating a health equity fellowship, hoping to have a fellow next year, heavily recruiting for that. And in addition to that, I'm also working with the medical school students, so the first years, and teaching their clinical skills through the PERCH curriculum, which is kind of the curriculum at UMass that focuses on social determinants of health.
All right, Dr. Farrell.
Hi, everybody. I'm Caitlin. I'm a second-year resident here at Baystate. Give you guys a little bit of background on me. So I've always been very interested in public health. I have my MPH from BU. I then went to med school at UNE. I see there are some UNE people on here. So did that. And then I actually did 2 years of family medicine residency before switching to EM. And what brought me to EM is actually social EM. I really felt that I wanted to be in the safety net area, treating these patients and working with these issues in a way that I wasn't able to do in family medicine. And I am very happy that I ended up at Baystate. It has given me a lot of opportunities, both in the realm of research as well as advocacy. So if you have specific questions, I'm happy to talk to you guys about any and all of those things.
All right, we're happy to talk about projects, but we can start with questions from you guys. Do you guys have any questions you've been thinking about?
So feel free to unmute for questions, but you can also throw them in the chat if it's difficult for you to, if wherever you're at, you're not able to unmute, you can put them in the chat too, and we'll read them out and answer those too.
So I have a question. I'm Jasmine. I'm a fourth year from Tufts. So I know that you talked a lot about how diverse your patient population is, which sounds really exciting. I'm just wondering, are there any patient populations that you don't see?
I'm sure there are. Caitlin, you want to answer this? What do you think?
Yeah, I think that, I mean, obviously, Native Americans are one population that we certainly don't see very much here. I think being in Massachusetts, as you know, training at Tufts, we are fortunate to have the majority of people be insured. In my prior residency, there were a lot of patients who were uninsured because it was in a different state. So we are fortunate to have that. But in terms of racial demographics, I do think it is a pretty diverse patient population.
We have, if you look strictly at our demographics, I think that patient population in the ED is probably about 20% African American and maybe 30% Latinx. Our Latinx population is largely Puerto Rican. We have a very large Puerto Rican population around here. But we do have immigrants from all over. We have a couple of refugee resettlement organizations in the area. So we have a handful of Somali or East African refugees, as well as Nepali. And we don't have the Cape Verdean population that Boston has. I saw one Cape Verdean patient last year, and I said, "Where did you come from?" Because we don't see Cape Verdeans. And she says, "I was in Boston, and they moved me to a homeless shelter in Springfield." And I was like, "Well, that's ridiculous, and I'm so sorry." So there's different sort of ethnic enclaves in different places, and so we don't get Cape Verdean the way that Boston does. And I think that the point that Caitlin makes about not having uninsured is a really interesting point when you're training, because it's really very variable all over the country. So we do not see a lot of people who have no insurance.
Hi, my name is Rashmi. I'm from Boston University. I was just wondering what kinds of programs you have in the emergency room for patients who come in, and the social programs that are available at Baystate for patients who come in who are from vulnerable populations, either homeless or are suffering from substance use disorder. Are there any programs set in place that you could access right there in the ED? Thank you.
That's probably going to be me, huh? Yeah, so it really varies. It's a little bit hard because I think the things that we do kind of transcend outside the emergency department. And so, to think what takes place in the emergency department, but what takes place because something has happened in the emergency department as well. So for example, for substance use disorder. So, as background, obviously opioid use disorder in New England, for those that may not be from New England, is very high. We have across the country higher rates of opioids, and in fact lower rates of methamphetamine. I don't know if people are from the West Coast or California. I trained out there, and I was surprised by the lack of methamphetamine here. Pleasantly surprised for now. So, for these populations in general, we have resources, and what we've done is we've tried to design it with respect to the emergency department, which, being a big academic center in Western Massachusetts, we are busy. So to simply keep someone in the emergency department for many hours is not feasible and would likely lead to people not doing it. So in fact, a lot of what we have is meant to be as a starting point for people with opioid use disorder, asking them, ascertaining if they want medication or not, harm reduction resources, trying to figure out how we can help. And from there, what we try to do is then work on the back end and connect with them once they're discharged. And we have a few unique ways of doing that. We have kind of a small team of folks that will call afterwards and kind of initiate follow-up and see how people are doing, whether they've gotten Suboxone, or for some that don't. We are also starting telehealth. So actually unique, and because of some of the restrictions being softened due to coronavirus, we have permission. So it used to be kind of not forbidden, but not reimbursable to do some of these telehealth things, especially around substance use disorder. And now, because of some loosening of those restrictions, we're actually doing post-ED visit telehealth for folks that come in with opioid use disorder, which is kind of an interesting new area. And in fact, I have a small grant to look at that post-ED harm reduction resources and telehealth to see if that helps get folks into follow-up. So there are there are a lot of these things and a lot of these small resources we try to give to people, with the idea that we also need to be mindful that if it's a 3-hour intervention in the emergency department, it's never going to work. The people don't want to stay that long. Other things, the providers, we can't clog up that much. So that's what we've tried to design, and there is lots of room for improvement. So, I think that's one of the nice things is we're very open. Everyone has different experiences. Everyone has seen different models. And so the things that you have seen work, I think we're always interested in incorporating that in.
Yeah, Rashmi, I will add that you're at Boston Medical Center.
Yeah, so I've done a lot of work in the BMC ED, so I was just asking about what the similar programs at Baystate, because I know we have something called the VIAP, which is Violence Intervention Advocacy Program, where for domestic violence patients, we have faster paths, which connects patients with substance use disorder directly to rehab centers. So I was just asking about Baystate similar programs.
I will say you guys have more programs than us, 100%. And that is, it has a lot to do with Boston Medical Center, and the history of Boston Medical Center has always had a focus on social emergency medicine, right? That was the goal of Boston Medical Center, was to take care of the people who were not being taken care of by the traditional systems. And I think that Boston Medical Center, I'm not saying BMC because we're BMC too, and so is Berkshire, so I can't just say BMC. But so Boston Medical Center is actually really a model for all of us for sort of holistic care. For example, I think you guys, and I know other hospitals have linkages to legal services in the emergency room. So when you're talking to a patient and being evicted is one of the things that's contributing to their diabetes, in poor control, you say, oh, well, when we're done with this visit, go to the foyer of the hospital and there's a legal counter and they will hook you up and that sort of thing. And so that we do not have legal services. We have a lot of opportunities to create better things. And our community has resources, but the linkages from the community to the emergency room is always a big challenge. So there's some things that I think that we're on the leading edge of, such as really getting the buprenorphine out, and there's other places where we've got lots of work to do.
Thank you so much.
Hey, I had a question. My name is Bree. I go to school in Little Rock. This may not actually be a thing for you guys, considering most of your patients are insured. That's amazing. But are there any programs that residents are involved in with either free or low-cost clinics or free screening health services that help patients before they even have to come to the emergency room that you can get involved with?
Caitlin, do we have any linkages with the clinics that we end up working at? I think the medicine clinic, the medicine residents certainly work at some of our clinics.
So we don't, as far as I'm aware of. I know Adam was saying that or the APD is hanging over here. I'm sure.
Hello, I'm Adam Kellogg. I'm one of the associate directors here, the Residency. I'm here to do AV support for all the Zoom stuff. and was planning to sort of stay out of the way. When I got here, I've been here for about 15 years, and there were multiple free clinics in the area, and I started working at them, got pulled into it by some of the faculty who were here. We used to bring the residents to them, and as Massachusetts got better and better at signing people up for healthcare and more access, they all went out of business for lack of having enough patients to take care of, which is an amazing problem to have. There's a pretty active healthcare for the homeless clinic downtown. I know Bill has done a bunch of work with them through the pandemic, but that's one of the few remaining services, because it's become something like, this is actually a fixable problem. If we get insurance for everybody, we can actually not need things like free clinics.
And I will say that I think I don't know like what your interest is in terms of things like that, but if your interest is in more care outside of the emergency department, street medicine, or longitudinal care, there are definitely other opportunities for similar experiences. We have 2 electives which you're able to use, doing pretty much, if you can imagine it, you can do it. So whether that's, an addiction clinic, people have done that for more longitudinal care. Setting up something at Healthcare for the Homeless, either here in Springfield or in Boston, doing the Indian Health Service. There are definitely opportunities. You just have to know what you want to do. But the administration here will definitely help you have those experiences if that's something that you want.
Awesome. Thanks, guys. Yeah, that seems like a good problem to have, is to where you don't really need those free clinics. That's amazing.
Hi, I'm Catherine from the University of Iowa. I'm kind of like in shock of everything that you're telling me right now, because this is like very different than the middle of nowhere in Iowa. But I was wondering how social EM is kind of built into your didactics, and what kind of exposure all of the residents get to concepts in social EM, rather than just like specific residents who want to pursue extra stuff in this.
So I'm happy to speak to that. So as someone who has like drank the Kool-Aid of social EM for a very long time, I would say that, we do have exposure, but I would argue that we could use more. But I think that that's also a great place to be. When I was thinking about where I wanted to go for my training, I think it is important to understand what it is that you're interested in social EM, and be able to explain why it's important, and sort of help others within emergency medicine, not just sort of like preach to the choir, right? So I think that within our own programming, we have what's called War Club, which is wellness and resiliency. We do cover certain topics within that. It's sort of like our journal club thing, sort of. We go through implicit bias training. We do things like that. We also have a special populations lecture series that is longitudinal. So my lecture is on incarcerated patients. We have, different vulnerable patient populations that we discuss. But I definitely think there's always room for more social justice curriculum.
Hi. After you.
Hi, I'm Bree. I'm from UNE in Biddeford, Maine. I did my 3rd-year rotation in Bangor, and I was impressed with the community family. It's kind of like a community health that they set up that was on the same EMR as the hospital. And so I was curious how the family med clinics or the community clinics are linked to your hospital, and how the transfer of care, how smooth it is, and if you're on the same EMR so that records don't get lost, or how do you prevent it from getting lost if you're on different EMRs?
Well, that's an easy one. I feel like I'm like, ooh, an easy one. So most of the clinics that see the Medicaid population are actually Baystate clinics. And so they're all within our EMR, which is really nice. So I would say the majority of primary care in Western Mass is linked to us, but it's not all of it. So there are definitely primary care doctors' offices and some specialists whose notes we can't see. But we have a pretty extensive EMR, and I actually think that, and I could be wrong about the details, actually Adam might know. I think that when Baystate made its electronic health system years ago, they actually invited local offices to join it regardless of whether they were a Baystate system or not. And so they got people on the EHR who aren't necessarily even Baystate. So it's actually pretty extensive. When you open up the EHR, it is a rare time where you get a record that's totally blank. You usually get some history on the patient, and often you get everything. And you have a fairly extensive history, which is really great for continuity of care and for knowing really what their needs are.
Great, thank you.
I will say as a caveat, unfortunately, Friends of the Homeless, which manages the Worthington Street shelter, which is the main shelter, is on the other system. So there are two main hospitals, and that is on the other system. We've been trying to work with them. And actually, one of our longtime ER nurses of 30 years is now their head nurse. And so we've been working to try to come up with a better system when folks get transferred to and from the shelter as far as passing information. And the other thing that's been really helpful that they are on is Cortex. I don't know if you have experienced Cortex. Some have, some haven't. But basically, it's a HIPAA-compliant, secure texting mechanism where providers are on it. And so I do most of the follow-up for folks started on buprenorphine, and when I'm able to core text a provider, literally just search them, write them a text, their ability to reply to me, it's amazing versus trying to have to call the office and figure that out. And that's true for things outside of social emergency medicine. That's true for your orthopedic consult, when you can just text them and say, I have this, and they can text you back with a recommendation versus having to page and wait for that. So there are a few systems where folks aren't on that can supplement and do a pretty decent job.
The other thing for continuity of care that our EMR does is for the clinics that are on our system, every time a patient comes to the emergency department, there's an automatic message. You can send your own message to the physician that is in charge of that patient, or the nurse practitioner or advanced provider that's in charge of that patient, if you have like a question or a comment or what the patient needs follow up with. But there'll also be an automatic message that reminds the patient, or the provider, that the patient was in the ER and needs follow up. So it lets that office make sure to get in contact with that patient, which I think is really helpful.
Yeah, the other thing that we're doing is we're also working with like the outpatient group for patients who don't have PCPs. And so if we give them like a referral number, right now we're doing it mostly for COVID patients who come in and they need to get their test results back, but if they don't have a PCP, we have like an outpatient coordinator who will try to call them and actually make sure that they follow up, because we often give them the number, but they may not always actually follow through. So I think that's one way we usually try to get people in our system. And that would be another way we could probably even use when we're expanding some of our social EM initiatives.
Hi, my name is Zach. I'm currently stationed with a Marine unit in the Navy. I'd love to hear a bit more about experiences to get involved in special populations, such as transgender health, prison and jail populations in the veteran community. Are there electives that residents have done recently with any of these vulnerable or unique populations? And are there any programs that support those specifically?
So I don't know of anyone that's gone to the jail. We do see a lot of prisoners within the ED. They do come. It's something that I'm talking to our program director about. It's certainly a possibility in terms of something to do as an elective. I did a rotation again during my last residency in a jail. And then in terms of the transgender population, there's a clinic. Okay.
Yeah,
So
there's a whole provider care team that that is the primary within Baystate for most of. So there's a one primary care clinic group within Baystate, but I don't know anyone's actually gone and rotated with them to be like within their office basic setup.
yeah, but they are also part of our special populations lecture, is caring for the transgender patients specifically. So we always get lectures on that topic.
And experience.
And,
We do
yes,
have,
and experience.
yeah, we have a lot of we have several connections with people who are working within the prison population, and there's actually a couple of research projects involved. We have, as Bill mentioned, there's a lot of stuff about treatment of opioid use disorder within the prison population, because if you start someone on methadone or Suboxone when they're in the or when they're in jail, they're going to do better than if you just let them have horrible withdrawal and whatnot. So there's actually a lot of work being done in the prison populations within that. And so if this, just like as Caitlin said, if this is something you're interested in, there's a ton of opportunities. And then Baystate has a lot of transgender care going on. And Northampton, I know a friend of mine is trying to start an independent transgender health clinic up in Northampton as well. So there's a lot of different opportunities to be involved.
And in terms of veteran health, there certainly could be an opportunity if somebody is interested to do an elective in that. We have the Soldiers Home in Holyoke, and then Veterans Hospital, it's a little bit smaller in Northampton, that has their own emergency department, but it obviously doesn't see like real emergencies, to the best of my knowledge, that anybody that is sick gets sent down to us or to Cooley Dickinson, which is the hospital in Northampton.
Yeah, we actually, I would say we actually probably have some disparities in veterans care in Western Mass, just because we actually don't have an inpatient medical hospital for veterans. So if you are if you're a vet who goes to the Northampton VA and requires inpatient medical care, I think you may get transferred. They have inpatient psychiatric care and they have outpatient care, but they stopped having inpatient care at some point. So I think they get transferred to care elsewhere. Or they get cared for at Cooley or Holyoke. I'm not totally sure.
Tyler may know. We could refer you, Tyler Christensen.
I would know.
He graduated, I don't even know how long ago, 4 years ago now, something like that, who works at, is he back at Wing? He was at Mercy before, but.
He's at Mercy.
What's that?
He's at Mercy.
He's at
Mercy. But yeah, we could connect you with someone who would have more knowledge as far as the landscape of Veterans Affairs and active military here.
Thank you for all those answers.
I have a question. My name is Robert Bratcher. I'm also from Tufts in Boston. Just kind of branching off that question. You guys said you have a lot of transgender team in the hospital, but how equipped do you feel the residents within the emergency medicine residency and just the emergency room in general are for taking care of like LGBTQ patients and using proper pronouns and knowing specific pathologies and like things they need to look out for that other people might otherwise not consider?
So I would say, and I would love for everyone to weigh in on this, I would say that every place has a long way to go, but I would say that Baystate is actually doing pretty well. So as some of you know, Western Mass is known as an excellent place for lesbian couples to raise children. So, my kids grew up never expecting that someone's two parents were any particular gender, which is really nice. That being said, less than a year ago or less than 2 years ago, I had to fight with registration because they had the wrong gender on someone's wristband. And it was more difficult than it should have been. And so it's an evolution. And some people do a great job and other people have a hard time, but the hospital itself is very committed to being inclusive. There's a lot of educational stuff. And I would say that our residents are probably better than as good as or better than anywhere else in the country for giving good care to transgender populations, because I think we talk about it a lot and we're super sensitive to it. But I think that as a system, every place has some work to do. And I would love the other thoughts of the other people who've worked at Baystate.
I think so. I think we, as residents, feel pretty comfortable. Like Elizabeth said, you know, no place is perfect and every place has a long way to go. But we definitely get a lot of exposure, a lot of lectures. We have a very inclusive residency as well as faculty. One of the residents this year, she organized so that we all have pronoun pins that we wear, just so every one of the residents and multiple faculty members have these, which is just a small thing, but it is, you know, just part of our general culture.
I think having trained at Baystate, there's definitely been a lot more of an evolution since I was an intern to now what is in the curriculum. And I think that's one of the great things about Baystate is we have like a curriculum committee that Adam is like a part of and leads, and they really basically residents have a lot of say in what they want to learn and what they want to add to their curriculum. So it's not just a static curriculum, it's dynamic, and I think that's really useful for things that are constantly evolving.
And I think to echo what Elizabeth said, for those of us that especially are attendings and have lived here for a while, you know, it's one thing to have the isolated experience in the emergency department, but to be in a place and to feel that, you know, comfort not only just in work, but in life and home, and to know that your kids know about this too, and it just becomes part of kind of normal life where you don't, you know, it doesn't become kind of a special population per se, is a really important aspect, and, you know, can be one of the decisions. You guys aren't thinking about this, but at some point you'll actually have to decide where to live and where to stay. And in thinking about that, not only the diversity of the populations that you see, but thinking about the diversities of the place that you and possibly your family will grow up in is really important.
Yeah, and to add to that, although I did my fellowship here, I did my residency elsewhere, and I have to say in comparison, I feel like most people at Baystate are pretty in tune with that. And I feel like you know, a lot of people often go in the room often asking you, what is your preferred pronoun? And we kind of have that more in our forethought. So I think we do have a long way to go, like Elizabeth said, because oftentimes, you know, we still have mistakes in our EMR, but I feel like we already kind of have that in our mind in terms of like how to address them. And like I said, definitely have more to learn, definitely more that we can add to the curriculum. So whatever you guys would be interested in, if you do decide to come here, there's always room for that.
Awesome. Thanks for answering, guys.
It looks like we have a question in the chat, Elizabeth.
Yes, I saw that, but I don't know if we actually lost Allie because they got kicked off. Oh no, there you are. Okay, cool. There we go. And you're being quiet because you're in the hallway. Got it. All right. So, how present and visible is social work in the ED? How do you follow up in the community? Do you have teams going to homes? So we didn't explicitly talk about social work in the ED. So we don't actually have great social work in the ED, and I'll let Bill talk about it. We have a lot of follow-up care, and we have a lot of opportunities for addressing things in the community, but we don't have a ton of social work in the ED. We actually only have, for a hospital of our size, we're rather deficient. We have 12 hours of dedicated social work in the ED, and if you needed someone outside of those 12 hours, you could call someone in on call. But when I get there at midnight, there's not somebody there to deal with something at 1 a.m. And I'll let Bill talk about some of the follow-up stuff that we have.
Sure. So yeah, and to quantify, we have great social workers. The few of them that are here are amazing people. But I totally agree that having more social work is a deficiency that we would really benefit from. I'm not as familiar. What's the hotspotting model out of Camden? Does anybody know? Is it specific? Is it general? It was just
it's that Atul Gawande article, right? Where they specifically identified patients who were like high utilizers of the emergency department and then would send teams out.
Bill, I think it's very similar to some of the stuff that you've been working on with the task force or whatever your group is called.
Yeah, so there's a few different, and it kind of depends on what the group is, right? So in general, for if you're talking about more frequent utilizers and things like that, actually, the chair of the department, Niels, has done a lot of work to try to provide continuity of care. So we have kind of notifications for folks that are very frequent utilizers for different diagnoses, abdominal pain and things like that. And although part of the goal is thinking about substance use and things like that, the other part is to provide continuity of care, because these kind of care plans have been basically the administration from emergency department has come together with all of the person's physicians and other providers, and together have kind of devised a plan for how we are going to do this. So from just the high utilizer standpoint, we try to address it that way. The other thing in trying to address are some of the ACOs that are available. So the accountable care organizations, or basically folks trying to, if they're part of an ACO, and there are two, there's one that's the Be Healthy ACO, which services mass health patients in our community clinics. Their specific goal is to try to kind of do this follow-up and avoid, try to address utilization and things like that. As far as specific to substance use disorder, we do, as a county, have teams that go out. It is city specific, in that, for reasons beyond this call, thinking about HIPAA and who gets the call first, and if it's information from the police, and are police willing to go out or not. There are different organizations throughout kind of the county and different cities that will do post-overdose outreach and other types of things. But there are a lot of different aspects, and it's somewhat piecemeal because of a lot of different reasons of local politics and HIPAA and things like that. So there are opportunities. How many opportunities as a resident gets a little bit hard. And again, I think it gets back. I know some of you are deciding, but I think it somewhat gets back to kind of your experience and what you're looking and expectations of a 3-year program versus a 4-year program, as far as your time and ability to do that. And there is no kind of right or wrong answer. Half of us on here have done 3 years, half of us have done 4 years. Caitlin's done like 10 years. So, but it does, I think one of the differences that is visible is the amount of time. You're an excellent provider. Is the amount of time you have to do some of these things. And you have to be aware, in a 3-year curriculum, there just is less built-in time as far as time to do some of that stuff. Not that you can't, and definitely you'll have opportunities to. But it is something to think about. But also, how important is that versus spending another year? So those are all things that you can balance, that folks can talk about more. If you really wanted something and to get involved in something, I think there's enough of us who have those contacts that could get you involved. But realize it can be really hard, because you might want to get involved and it's a great month, and then you hit SICU and you were like, I can't be involved in anything but SICU. Or something like that. And that's kind of part of residency in general. So
I think, and this is my spiel about Baystate when it comes to social EM, when it comes to research, comes to this. We are a really big hospital with a lot of need, and we don't come from the same place. We're not Harvard. We're not Boston Medical Center. You can come here and do what you want to do, because the need is there, and we will help you find the way to do it. But you're not going to come here and get plugged into a program that has a massive infrastructure, that you have, 8 mentors who are doing exactly what you want to do. So you get to come and forge and make your own path, particularly within social emergency medicine. And we will find leaders and mentors and that sort of thing, but it's not the same as being like, well, I'm going to go to Brown where there's this injury prevention center, and I'm going to get plugged into this massive injury prevention center. So there's a lot of opportunities here, but to some degree, you're foraging your own road for some of those. But we're very, very supportive of that.
And I would say that the administration is very, very supportive, like everyone is saying. I remember when I interviewed here, I had specific things that I knew I wanted to do and be involved in, continue from my previous training. And I basically said, like, how can we make this happen? And we've made everything happen. Ben is amazing. Our APDs are amazing. If you have something that you want to do, they will help you get there. Even if we don't have like all of these established centers, you know, the resident interests are very diverse. We have a whole group of people that love wilderness medicine. Like, I hate hiking, you know, so it just like totally depends, but they want you to be able to do what you want to do. And I think that that is a really important thing in a residency.
You're welcome to ask general questions too. You don't have to ask specific social EM questions.
I had a quick question on that. So my name's Seth. I'm also from the University of New England. So related to kind of just the design your own path, do students get the opportunity to get both the national level social EM as well as the local level social EM experience?
Yeah, I will say, not to just be talking so much, but so I definitely have had the opportunities to do both national as well as local. My local involvement is more research projects with Bill and Elizabeth, but on a national level, I'm one of the vice chairs to the EMRA Social EM Committee. I'm the vice chair of the Massachusetts Medical Society, and I'm a delegate to the AMA. So I'm able to write a lot of policy through those organizations. So depending on what you would like to do, those opportunities are there for sure.
She's doing something.
And then
you're here for a year with Caitlin.
Yeah, she didn't even mention some of them. She's also on the organizing committee for the consensus conference in the spring, which is like, so she's on so many things that she's like, oh, well, that was number 4, so I didn't mention it. Allie asked another question to follow up on what Dr. Farrell's saying. Does Baystate's EM graduates and attendings have a lot of representation in the leadership of the hospital? I think we are, our department is really well respected in the hospital. So I will say, so not to toot our own horns, I think our residency is the single most highly respected residency in a hospital. And I don't have any official data to prove that, but I think that we are the highest. We just have a very good residency, and we are considered very highly in that respect. I think we have good relationships with hospital leadership. The hospital, works to, work as an institution and get things done. We actually, this is a better question for Vanna. I'm gonna kick this one over to you to talk about how the interplay between the ED leadership and the hospital leadership, because it's a very admin question that I don't totally know the answer.
Yeah, I mean, in terms of just hospital administration, I feel like we work closely with hospital administration. Like, we have our chairman, Dr. Ratcliffe, as well as Joe, who all work closely with like the CMO, who know the CEO, in terms of what, in terms of ED presence within hospital roles or titles. Like, we don't necessarily have like an ED visitor who is the CMO or who's the chief nursing officer. So that part, I can't say we've necessarily infiltrated as much, but I do feel like we have a good working relationship with the hospital administrators. There's definitely room for improvement, which we are currently working on. Otherwise, I would say we do have like a strong ED leadership. We have, at least we can see their presence. We know our vice chair is someone who we can always approach. We can always email or talk anytime that we have questions. Same thing with our chairman or associate chairs. And I feel like everybody also feels like they can always bring up any concerns, and it will probably get to the person that it needs to, whether or not it's our vice chair or someone higher up in the hospital administration. I don't know if that answers it, or if I can answer anything else in particular.
These are great questions. These are not things that I was thinking of when I was a medical student, so I'm impressed.
I have a quick question. I'm Steph. I'm a 4th year from NYITCom in New York. I was wondering what the translational services look like in the ED, especially given the large Latinx population that you guys take care of.
I think we're pretty great. So there is 24-hour in the hospital Spanish translators. I'm going to guess multiple. And so if you have someone who's critically ill, I don't know that I've ever, first of all, a lot of people in the ED speak Spanish, a lot of staff and providers. But if you needed a translator in 5 minutes because, or 2 minutes because of a trauma, the Spanish translators are there like that. You can get in person for a lot of other things, but you can also we have the translating app on the iPad is often your best bet because it is super fast and it's very functional. I've worked at other places where it's like you spend 20 minutes futzing with it, but it's usually pretty functional. So we can get a Nepali translator, within a half an hour every time I've called for Nepali, or you can use the app for some of the ones that you're less likely to have at your fingertips. We kept the Russian translator quite busy. A couple months ago, there was one point where I needed a Russian translator for 3 patients at the same time, like 3 sick Russian-speaking patients, but that was related to COVID at one of our local churches. But yeah, other folks' experience with translation services?
No, I would say it's great. And I would say for some, like Russian and Portuguese and others that are somewhat smaller populations, a lot of the time, the interpreter, when they come in, will know the person. And they'll say, oh, I just saw them at this visit, or I saw them here. And actually, that's great. I mean, you get some insight into this is how this person is normally, or no, they're very different now than some of that. So that has really been, they're very good. They're very good.
Yeah, I think our in-person translators are good. Unfortunately, I don't always agree that the Stratus is always that great, especially with certain dialects. You have patients that come in that speak a certain dialect from, a country in Asia, and they can't really understand. And then also for our elderly patients who are hard of hearing, the Stratus is very difficult. But that's not something that's unique to Baystate. I think that you're going to see that across, like, everywhere that you go. I mean, what's good is that we have the Stratus available, but there are definitely some kinks.
Yeah.
Thank you.
Anything else? What else from us? Anything else we should tell them? We should make sure they know. Caitlin's logging back in.
And just out of respect for people's time, I think we should wrap up at 2:00. I know folks have lots of things they have to do, but thank you so much for coming and being a part of this. If you have any other questions, please feel free to send them our way.
I'm happy to put my email in the chat if you guys have like residency specific questions that you want to ask. I can type that in now. But yeah.
Yeah, and I guess, last advice, I have to think back to how many years ago when I was looking at residency. I think in terms of social emergency medicine and your abilities, really getting a sense of the culture of the place is really important. Places can have programs, they cannot have programs, but if that culture is not there, that kind of culture of service and addressing social needs and that recognition, then even if there are some programs, they're not going to hold traction, or they're not going to be kind of what you expect from that. And I know with coronavirus, it is probably much more difficult to get a sense of that. But if you can, more than kind of the specifics, I think what is there is how are the people and who are they treating, and what are their kind of attitudes towards people that are different, that have social needs. I think that'll get you far as you're deciding where to go.
All right, thank you guys for coming. I think we'll leave this open so you can pull all the email addresses out of the chat, but feel free to drop us emails, and good luck with your year and your match.